With further ado, we're very fortunate to have Dr. Veronica Campanella here today to discuss pediatric anaphylaxis. Dr. Campanella is in her first year of pediatric emergency medicine fellowship at HSC Winnipeg Children's Hospital. She previously worked in the pediatric emergency department at Children's National in Washington, D.C., prior to fellowship with specific interest in pre-hospital pediatric care. And now I'll turn it over to you, Dr. Campanella. Thank you.
Thank you. Hi, everybody. I have a couple interactive things too, if you want to put them in the chat, but it's also pretty obvious answers, I feel like. So feel free to answer in the chat if you want to, and then I'll like a short break in between those. So in general, the goals of today is just to discuss the presentation and like to try and recognize anaphylaxis in children, and then know the rationale behind the use of epinephrine as the first-line treatment for anaphylaxis, and then consider other adjunct therapies as needed throughout their care. And then also understand why antihistamines are not a treatment, and those kids who may be at more greater risk for severe reactions. So in general, anaphylaxis is just an acute systemic allergic reaction that can be mild, life-threatening, or fatal. The fatality of anaphylaxis is 0.1%, so still relatively rare, but the fatality of a car accident is also without a seatbelt is 0.1%, so still very relevant. We still wear our seatbelts. This is going to be more of a ED perspective, so like a pre-hospital and hospital care, not the nitty-gritty immunologic of what anaphylaxis is. In general, though, several studies have shown that anaphylaxis as a whole is under-recognized by both parents, caregivers, and underdiagnosed by healthcare professionals. So then again, undertreated, and which can again lead to this fatality. Failure and delays of giving like epinephrine are associated with these near fatal or fatal reactions. So in general, in doubt, treat. Give IM epi. If you're thinking about it, just give it, as the theme of this lecture will be. In general, there is no strict contraindications to epinephrine in children, and most of the side effects would be like a pallor or palpitations are transient, and they do improve throughout. So even if you were wrong, it is okay. You could just refer to allergy at the end of the day if they do well after IM epi, and then if you think about it, or if you're able to, where you are, you can send a tryptase, which may help allergy, but it's not needed. So just in doubt, treat. On the TREKK website, there is an anaphylaxis algorithm. There it's helpful. There's multiple things that can be helpful on the site, but they do have the recognition of anaphylaxis, the initial management, and then like the timeline of like 5 to 10, 10 to 15, 15 to 20 of continuing treatment, all there on the site. They also have that you can print out a special little card that you could put on your ID badge. They have the little punch hole, and you can like laminate it and put it on, which has this in a little bit easier format to keep on you if desired. And we'll go through this a little bit more detail throughout the lecture. Just have a case. So going to start as a paramedic, going to the scene, you were called that there was a 3-year-old boy. He was playing at a friend's house. The mom called 911 because he suddenly started to cough, have a red face, and he was itchy all over. This is what you see on exam, this erythematous rash with some swollen lips. He's crying, anxious, he's coughing with stridor and wheezing. And then he has a moderate work of breathing. He's satting 94% on room air, and then his respiratory rate's 36. So what would your diagnosis be in this case? I'm gonna say diagnosis would be anaphylaxis. So he had the skin manifestation, plus he had respiratory manifestations. So in general, anaphylaxis is an acute onset illness. So you didn't get this history because he was at a friend's house. This is common as a paramedic out in the field, or even if you were in the hospital and say he was at a friend's house and the family member is not there, they don't know his medical history. But in this case, we got a medical history later that he does have a peanut allergy, and at this friend's house, he got exposed to peanuts. So If you're unsure, again, treat with IM epi. This is anaphylaxis. So he had the skin. Skin is anything. So it could be urticaria, hives. It could be just some erythema of the face, swelling, like angioedema, as long as it's not in the posterior airway and just the lips. Angioedema is considered a skin manifestation alone. It is not indicative of anaphylaxis by itself. Then he also had the breathing. So skin plus something else. So skin plus respiratory. If you have short of breath, wheezing, coughing, they feel like their throat's tight, trouble breathing, stridor, upper airway congestion. They could just have skin plus GI symptoms. So they just ate something like a peanut, they get a rash, now they're vomiting, just repetitive vomiting. That's also anaphylaxis, and you should treat. And then a more severe anaphylaxis is usually with a cardiac manifestation. So this would be if they feel dizzy, lightheaded, or they're hypotensive. And then there is literature that suggests even neurologic symptoms, which is more common in infants. So recognizing anaphylaxis in an infant can be hard because they could just be persistently irritable and not calming down. If they're irritable initially with just the rash, that might not be. It's a hard symptom to go, but if it's not going away, I'd be very concerned for anaphylaxis. So skin plus irritability, persistent headache, altered mentation, I would also consider anaphylaxis. So in general, back to his case, his diagnosis is anaphylaxis. What would you think if there was no respiratory symptoms and only skin? So he only had the rash and the angioedema. I love it. So it's hard. So again, I was saying, if you're unsure, treat. If it's just skin, if it wasn't, so how it says, if we get back to it, it has to be acute onset. That's very important. So if he ate something or got a bee sting and it's within 5 minutes to an hour right after the exposure, that's more concerning for anaphylaxis than like a normal allergic urticaria. Urticaria is really common in kids. So we can see it with viral illnesses. We can see it with some like contact dermatitis, some allergies. Sometimes it's just idiopathic. So if it is that alone or angioedema alone, it may not be anaphylaxis. But again, if you're unsure, if it has any other symptoms at all, if they have a history of severe anaphylaxis, a history of needing EpiPen or exposure to a highly allergic substance, I would still give the IM-Epi and err on the side of caution. And then the treatment would be IM-Epi. Ideally in the field, earlier is better. They show a delay of over an hour of IM-Epi has increased the risk of severe anaphylaxis, needing hospitalization or even fatality. So if you are in the field, a paramedic, if they rush into your department, early is always better. So if you're thinking about it, trying to like waffle, again, antihistamines do not treat anaphylaxis. So if you give an antihistamine, so, oh, it's just skin, maybe it's not, it's going to delay that treatment of the IM-Epi and it's going to delay appropriate care and potentially mask some of the symptoms. So always think if this was given in the field, it might help, but just know IM-Epi early. And if you're unsure, just treat. So we have a second case. This is a 16-year-old girl who,
We have one question.
Yeah.
So up to an hour is considered immediate. How long till you start to consider not an immediate reaction?
If it's past an hour, I would think it's not immediate. So if they like ate a peanut, they were fine, they were walking around normal, then they got like a little itchy rash, it's not going to be severely hypotensive or like severe respiratory distress if they're not in severe anaphylaxis. So if it's just a rash alone and it's after an hour, like 2 hours later, they start to get a rash, I would be like, oh, this is definitely not anaphylaxis. I'd feel even more reassured. If that answers your question, hopefully. If they were in really big respiratory distress or if they were like hypotensive or anything, I would give IM-Epi. I would err on the side of caution because we don't know if that kid had re-exposure. Kids have sticky fingers, they steal things, they are tricky sometimes. You turn away for a second and they get into something. So just because the parents think it took more than an hour, it might actually not be. So if they have any of those secondary symptoms like respiratory distress or like hypotension or persistent GI vomiting, I would treat and err on the side of caution. But if it's just a rash and greater than an hour, very safe to just be like, okay. Yeah, if the rash fails to respond to epi, it does suggest allergy. So if it's only a rash and nothing else, the epi should treat it. They should be better because epinephrine would treat anaphylaxis and would treat most of the rash symptoms as well. If the rash is still there, I would just use preferably a second line generation. We do not use first generation antihistamines in kids because all it does is mask the symptoms and make it look like anaphylactic because it can cause like sedation. So cetirizine would be like first line, so like Reactin, and very standard dosing, like less than 2.5 mLs, 5 to 10, like 5 mLs, and then greater, like adult size, 10 mLs. And I would just treat that for the itch and comfort, and then that would be all. So if it's just rash alone, doesn't respond to epi, probably not anaphylactic. So going on to case 2, we have a 16-year-old girl who was brought in by EMS at 1:30 in the morning. She was at a party with a friend. EMS was called when she was found unconscious. So in general, the thought most likely what this could be, she's at a party, probably drinking, probably maybe she did some drugs, maybe she has diabetes and she's like in DKA, maybe someone assaulted her, she has some head trauma, someone drugged her, or if she didn't do drugs herself, or she had a seizure. These would probably be the top of your thoughts, but would you think anaphylaxis? I mean, it's an anaphylactic lecture. So in general, in this case, we had a 16-year-old CTAS 2, unconscious, intox, brought her to recess. She was a little bradycardic. She was very hypotensive. For her age, mildly tachypnic, lower GCS, normal glucose. She did not respond to naloxone. Sober friend was with her and swore that she did not drink. So on her body, we found a medic alert that she has a severe anaphylactic allergy to egg. We gave IM epi and she actually responded really well. She needed 2 doses, which we'll talk about in the treatment, how to redose and how to keep monitoring. So we just monitor her here for biphasic reaction, further improvement, and she did really well. So again, if it might not have been the top of your differential, it would not have been the top of mine either, but the problem with that diagnosis of skin plus something else is that skin alone is not needed in 10% of anaphylaxis. You can have severe other symptoms and you can call it anaphylaxis. So if you're not going to have skin manifestations, how I would treat is so say we tell parents when they go home, if they had anaphylaxis in the past to a peanut and they eat a peanut, you should just give the EpiPen. Treat preemptively. So highly allergic exposure by history is good enough without skin findings. If they have severe hypotension without skin findings, especially with an allergic history or allergic exposure, I would think of it. If they have severe upper respiratory obstruction or severe bronchospasm, especially if it's not, say, oh, we think it's asthma, you're treating with a bronchodilator or steroid and they're not responding, or nebulized epi and they're not responding, I would maybe think, oh, could this have been, again, like maybe foreign body, maybe something else, but if it's persistent, why not try IM epi? It's not going to hurt, and it could be anaphylaxis and they could respond. So there are cases in severe anaphylaxis that does not have the skin manifestations. Again, they should have other severe symptoms before I would go to IM epi. So
we have another question
oh, yeah.
in the chat. You can respond now or later. Is there any proof I have an allergic reaction to the smell of something? I have heard it many times, but some research I've done doesn't support a physical reaction, but can cause a psychological one. Sorry.
I don't know. In general, most allergies are to like the protein that you are exposed to in, like, say, bee stings, or that they inject or that you ingest, and you're not smelling the protein. So a lot of it is psychological, but I think there is something that can trigger, but I don't remember what it was. There is one that can, and I'm so sorry, I don't remember. I'd have to look it up and I can email it to everybody, the answer as well after this lecture. Just in general, for like risk factors of more severe anaphylaxis is adolescence. So like in that case before, they don't carry their EpiPen, they take risky behavior, they feel indestructible, right? So I guess she's smart that she's not doing illicit drugs or drinking, but not carrying her EpiPen, not telling people about her allergies, saying like not checking, say if she was allergic to like eggs, not checking the food, eating baked eggs, not thinking that might be a problem. Teenagers just do these behaviors naturally. Asthma, especially if they're poorly controlled. So if they have a trigger that is anaphylactic plus their asthma, it's more likely to be more severe because now you're controlling their asthma exacerbation plus their anaphylaxis. If they had a previous history of a severe reaction, then we're likely to have it again. If they don't, again, give their epi promptly, so it should be given within the first hour. If they're requiring multiple doses of epinephrine, that should be at least a little bit longer of observation, as they may have more severe and may need an admission. So distance from a hospital, again, falls into the not having the EpiPen and having failure to giving it for the hour. So if they live over an hour away, say even if like paramedics are far away from them, they don't get a good history, or is like presenting atypically, which is like hypertension, and they're not getting their epinephrine as promptly, and then taking beta blockers. So if a parent gives their child epi at home, they do not need to take them to the ER anymore. That is new guidelines. We do talk about in like disposition. In general, if they had an appropriate exposure, they gave the IM epinephrine, they appropriately responded to the IM epinephrine, so now everything is resolved and they don't need continuing doses, they do not need to come to the ER. That is why it's recommended for them to have 2 on them at all times. So if you're going to discharge them, you should prescribe 2 EpiPens at all times, just so they have a second in case it's needed. But if it's appropriate, they had no severe reactions in the past. They do well with 1 dose of epi. They have refills on them. They do not need to come to the ER anymore. It is like individual case by case, again, because if they had a history of asthma, a history of severe reactions, they should still come. But usually now their allergist is telling them this. And you can feel free to tell them when they discharge, if they responded to 1 dose of epi and you give them a pen and they have a future one, they do well, you can for sure tell them, empower them to stay close to home, especially if they live close to a hospital. I would be a little bit more hesitant if they do live far away from a hospital, because if they give it and they need repeated doses, it's going to just take longer to get there. So we have our next case. We have a 4-month-old baby who did have some formula supplementation with Infamil at birth, so for hypoglycemia, but that resolved. Mom's breast milk came in, and then he was exclusively breastfed. Unfortunately, now mom is sick, little dehydrated, not making good breast milk. So dad let mom sleep, gave some formula. After the formula, it was within 5 minutes, baby immediately started to vomit, was very irritable, and then a few, like 10 minutes later, had this rash. They came here for further evaluation, and then what do you guys think is the diagnosis? Based on this lecture, probably not surprised. So skin plus vomiting. So he has 2 features. So he has anaphylaxis. This is actually a very common thing that's happening with supplementation. Actually, still uncommon overall, but we do see it more and more in the ER. So something to think about, that you can develop a milk allergy. So if you are given something, you can get antibodies. And then if you take a long time not to expose it again, there is a risk. Again, it's pretty low, but possible, especially if they have a history of atopy, so like eczema, or family history of asthma. It's high on the likelihood. A lot of, if anyone does like newborn nursery, they're looking at supplementing with Nutramigen in the interim until breast milk comes in, instead of regular formula, because it doesn't have milk protein in it, so it decreases this risk. It's a little more gen peds, but that's okay. So he comes in, overall vitals are still okay. He still looks okay, but what would the treatment be? So in general, treatment should still be IM epi. He still has anaphylactic, it could still worsen. And if you don't treat within the first hour, he could still have more severe. So he comes in looking great now. He has anaphylaxis, vomiting plus the rash. Treat with IM epi. Tell them to avoid the offending agent. So if he has this and dad is actively feeding him more formula, I would be like, stop that formula. Let's switch to Nutramigen. This could happen in the hospital. You started ceftriaxone or like an antibiotic, it's running actively. Immediately they start to wheeze or something with a rash. I would stop the drug. That should be the first thing, because you're going to continuously give them anaphylactic reaction without stopping it. IM epi next, and then ABCs. Seems counterintuitive unless you don't know, like in our second case with the teenager, you might go to ABCs first. But if you know this is anaphylaxis, you should just give IM epi, because that is the treatment that will help immediately, and then go to the ABCs. Treat as needed. So give supplemental oxygen if needed, if they need to be intubated. I would, it depends on if it's like upper airway congestion, be a little bit hesitant and make sure you have a good airway plan for safety. Bronchodilators as needed, especially if they have a history of asthma. I would consider steroids. Steroids does not decrease biphasic reactions. It does not treat anaphylaxis. It may help with the rash. And the times I reserve it, it may help with severe recurrent refractory hypotension and shock. But otherwise, the only times I really use steroids if I'm treating a kid with anaphylaxis, if they have a history of asthma, and now it also triggered their asthma, because I need to treat their asthma, or if I'm really concerned for upper airway constriction and impending respiratory failure, because I want to decrease that edema. Again, if they have this upper stridor, they sound like grunting, I would give a nab epi, it wouldn't hurt. And then an adjunct therapy would be second generation antihistamines, preferably cetirizine in kids, and that's just really providing comfort for the rash. It's not treating anything else, but why not? And then if they're persistently hypertensive, it'd be fluids. TREKK has an order sheet online. If you're ever unsure, you can look. They have how often you monitor blood pressure and vitals. They have the first line treatment, which is, again, IM epinephrine. They have the dose in the chart. But again, in general, greater than 25 kilos would be the adult 0.3 mgs EpiPen, less would be 0.15. When in doubt, there's been shown a lot of mistakes with drawing it up. So yes, you could do the 0.01 mgs per kg, but you could always just, if you give a little bit more, it is okay to just give the EpiPen Junior if that's available. And then if they are like above about 50 kilos, and you have Emerade available, that would be preferred, which is the 0.5. But if not, you can just give the 0.3. Again, then adjunct medicine would be the antihistamine second generation. And then if you need a bronchodilator or inhaled epi or steroids for like how they say refractory shock, persistent shock, asthma, or upper airway congestion, and then fluid resuscitation for persistent hypotension as well. And then they talk about refractory anaphylaxis and when to keep giving it, which is on the guidelines, but also really nicely here for the order set. This is the Canadian Pediatric Society, like so CPS. So again, just to reiterate, if you see a patient that fits criteria for anaphylaxis, first line treatment, next thing you do is give the IM epi. And then you can repeat this IM epi every 5 to 15 minutes if symptoms persist. So if they still have the rash with the airway concern, the rash sometimes takes a little bit longer to go away than everything else. So I would wait the 15 minutes if it's just the rash. But if it's airway concerns or like hypertension, I would be doing it every 5 to 10 at least. Now you're going to initiate the ABCs, monitor, and then this is more like if you're going through the algorithm, if they are fine after the first one, ABCs are good, kind of go, if you reassess and clinical are good, you can observe. We will talk about TREKK has the most up-to-date as well. This CPS has not up-to-date yet. And the AAP, the American Academy of Pediatrics, also says 4 to 6 hours. So if you're unsure, you can always observe for 4 to 6 hours for a biphasic reaction. But again, how we're telling parents to go home early, it's based on UK data. TREKK also updated that for a mild anaphylactic reaction that responds well to epinephrine, you can discharge home in 2 hours as well. That is new guidelines. So if you're not comfortable, you can keep the 4 to 6 and then just discharge with good education on how to use an EpiPen, make sure they have prescription for EpiPen and access to it, and education with follow-up with an allergist or the pediatrician at least. And then again, you can follow the algorithm if they have airway compromise, preparing for intubation, bronchodilators, nab epi, again with hypotension, fluid resuscitation, plus minus need for steroids, just like we talked about before. I like cetirizine. It's not just myself, it's all of pediatrics in the US and Canada. We have stopped using Benadryl. Benadryl is so sedating. So if we're concerned about their neurostatus as like altered mentation and lethargy and sedation as a concern with a rash to being anaphylaxis, we might overtreat because Benadryl will just make them sleepy. We, as a whole, have moved away from using Benadryl. There is a lot of studies that show cetirizine is just as effective as Benadryl for urticaria and rash. So if we have a drug that's more effective or just as effective with less side effects, so they do not cause like that sedating side effect, we would prefer that. It's also standard dosing, so it's very safe to give, and easy, no thought process. It's either 2.5, 5, or 10 mLs. And unless you give like 30 mLs or higher, you're really not going to overdose on cetirizine. So IM-epi is the preferred, obviously. We do not give IV. I'll talk about it a little bit shorter. It's mostly because errors have been made. Can you give IV? Technically, yes, but way high risk for errors in cardiac side effects. And we're going to be dealing with more like a cardiac problem than the anaphylaxis. So nobody uses it. Again, if you do not feel comfortable drawing it up based on their kilograms, standard dosing is fine, using a 0.15, 0.3, or 0.5 if it's available. So they have multiple stuff available. The EpiPen would be orange to the thigh, blue to the sky. The Allerject is really nice because it actually talks to families, and right now it's the same cost. And then the Emerade is nice because it comes in a higher dose for more larger kids. So be great. Make sure they at least have one of these. You don't have to write all for a prescription. You could just write epinephrine auto injector, and then their insurance or whatever the pharmacy has available, they could be given. I don't know. Sorry, I'm reading the chat. Yeah, I saw that chart with the Benadryl, which we don't use. Thanks, Karen. And then there is like no IV option for antihistamine. I mean, technically, I know there's IV Benadryl, but we would not use IV Benadryl. And there's no need because the antihistamine is not treating the anaphylaxis. It's only treating the skin manifestation. So if you don't need the IV. It's really more for like, oh, they're upset and they're itchy. So, and if they're still vomiting, because they're not tolerating the oral cetirizine, then they're an anaphylactic. They need more IM epinephrine. It's an epi deficiency, not antihistamine deficiency. Yeah, so EMS should not be using Benadryl in the field. I know adding more and more medications is harder because if they're adding, because the adult data is not the same as peds yet. They have not caught up really to pediatrics. Usually we're behind than adults, and this is the only reverse one right now. Also, vet medicine isn't up there either. Because my dog needs it. They get anaphylactic from vaccines, so they need to be pre-treated. So Benadryl is still used in adults. So getting more and more medications and more protocols on like rigs and for paramedics is hard. It's more approval, more things to go through, getting it more available there. So should they use Benadryl at all? It's probably not, because the protocol in pediatrics should just be don't give it. If it's take away from here, if it is anaphylaxis, you just give IM-epi. They do not need Benadryl. They do not need even cetirizine. They need the IM-epi, and then they should be fine en route to the hospital. They're a little itchy. They're a little itchy. Also, just of note for like why we give it in the thigh. So the study is still kind of actually old, but it's a great study to show. So if you look at like the black triangle and squares, that's just saline. So of course it doesn't spike in your system. The green triangles is giving it sub-Q. So if you're giving a sub-Q drug subcutaneously, it is not absorbing high enough in the bloodstream that actually is going to be an effective dose to treat anyone, children with anaphylaxis. And then interestingly, because it's still sometimes done, which to take home from this, always in the thigh, is the blue square. As you can see, it does not spike. And that is giving IM epi in the arm, so in the deltoid. So IM epi should not be sub-Q. And if you think about it, if the kid's really morbidly obese, you might need a longer needle. If you're drawing it up, it's pretty well studied for the autoinjector in the thigh, and it cannot be in the arm. It has to be in the thigh. So the orange and the yellow is either being drawn up self or an autoinjector, and they both have high spikes. In general, the theory behind this was that your lateral vascularis and your like thigh is just more vascular than your arm. So that's why you're getting more spikes. And these second spikes could be either endogenous, your body's starting to create more, although it should be there for all of them. So most likely is that you get some like local vasoconstriction from the epi itself. And then once that kind of titers down, you absorb more. So you get those secondary spikes of the epinephrine after when it's in the thigh. Again, you avoid IV unless they require more than 3 doses of IM. They may require an IV epi drip. If you're going to use a drip and they still need IM epi, you still continue to give IM epi every 5 to 15 minutes as needed until the drip is established. Again, the drip is there because it's going to be per mg per kg. We have the mics per kilogram, and you can titrate it. You just start at 0.02 and you titrate up as needed. And then this is just avoiding mistakes and side effects. So this is just talking about how IM epi every 5 to 10 minutes as needed. IV only if they're persistently hypertensive after the 3rd doses. Again, you can keep giving IM if needed while you're setting up your drip. You can consider at this point, if they're still hypotensive, fluid resuscitation with a bolus. If they are small, you should just pull the fluid. So like just take the fluid out of a bag and then push it into the patient, or just flushes for really small kids, just keep pushing flushes. If they're over like 40 kilos and they can get like a full bag, just do as you would do in adults and like pressure bag it in if they're very hypertensive. In general, if they take a beta blocker, which is a little bit more rare in kids, but you may see it, epinephrine may be less effective. And then if they're still hypertensive or still having a severe reaction, you should consider glucagon as the ideal treatment. So we have another case. This was when I was a resident, 7-year-old male with autism spectrum disorder. He was rummaging through the garbage at school, eating something, but he does have a known peanut allergy. He started having a cough and a rash. The school gave EpiPen and called 911. They arrived to ER. He's in respiratory distress. He had stridor. He was very hypotensive, very sick appearing. So again, what would be the diagnosis? Would be this point's refractory anaphylaxis. He already had his EpiPen, but yes, anaphylaxis. And then treatment, if I didn't say enough, would be IM epi. And for him, because interestingly, he needed multiple doses of IM epi. He started on an epi drip and a norepi drip fluids, and he was intubated and admitted to the PICU. Just as a follow-up for this case, in the PICU, he wasn't getting actually, even though it was ordered, his oral hygiene from the nurses. A nursing student brushed his teeth, found this ball of peanut butter, and like mentioned it to us that we must have missed when we intubated, and kept treating. And then we washed the peanut butter away, and he was extubated and did really well. So it's great. Thought of just remember that the offending agent, no matter how much you treat with epi, if you do not remove that offending agent, if you don't stop the running antibiotics, if you don't do a good exam, especially kids with autism who can't speak to you, or little kids who can't speak to you, that none of the treatments are going to work. No, if they're in anaphylaxis, you still give epi with the cardiac history. They may be a little bit less comfortable dealing with their tachycardia, and if they might become more hypertensive in the setting of if they don't have as good perfusion, or if they have like pre-cardiac surgery, depending on their lesion. Most kids with cardiac post-surgery will do fine, and there's no contraindication. And still no contraindication pre-cardiac surgery, but you might just need to watch them a little bit closer with their tachycardia. Just in general, some extra treatment considerations that we still kind of talked about throughout is that antihistamines do not treat anaphylaxis. It treats urticaria. it also can cause these delays in the treatment. So, oops, how did I do that? So like the delays can be, oh, I'm just going to give some cetirizine and I'm just going to wait and see. Maybe it's just the rash, maybe it'll get better. And then if now again, you're giving it later than 1 hour. And now since that hour has passed, they might have higher risk of severe anaphylaxis or fatality. It also, if you're giving like a first generation like Benadryl, it can be confused as lethargy and increase the likelihood of misdiagnosis, as well as like length of stay and care the kid is getting. So second generation, if given, is more preferred. I know CPS still says H2 blockers as well, so like ranitidine, which in general, as long as they're tolerating oral intake, it's not going to hurt. It might not help. There's not good studies that show that it will help, but if you do have ranitidine and you want to give it, maybe it will help some of the highs, but probably not. No push dose of epi, I do not. Unless they are coding and you're doing CPR, then I would do a push dose of IV epi, but we don't recommend any bolus because it increases the risk of treatment mismanagement and overdosing usually in pediatric patients because the dose changes for IV so rapidly. So I would just continue IM epi if needed, and then just start the infusion when it gets ready and primed. So again, like treatment consideration, steroids, some may help some skin manifestations, maybe, but it does not decrease biphasic reactions, and it actually might slightly increase it based on some data. And I personally only use steroids if they have, like, if I'm concerned about worsening upper airway edema, especially if I'm about to intubate or like impending respiratory failure, I would do a steroid. If they have underlying bronchospasm and underlying severe asthma, I would do a steroid more to treat their asthma than to treat anything else. And then if they're in refractory shock, you're giving fluids, you're giving the epidrip, maybe you started a second pressor like norepi or glucagon, and they're still bad, I would try a dose of steroid because your body makes endogenous steroids and maybe it just needs a little bit of help. And then again, so just talking about some biphasic reactions, the risk is up to 15%. Some literature says 6, some say up to 20, but on average, most say 15%. This risk factors for getting a biphasic reaction is anaphylaxis to a drug in particular, or if we don't know the trigger, they just got an anaphylactic reaction of unknown source. If they have severe anaphylaxis can be defined as cardiac signs, so hypertension, or when they present in triage, they have a wide pulse pressure right out the gate. Also, definition of severe anaphylaxis, if they have respiratory signs, so severe hypoxemia, severe persistent wheeze or respiratory distress. And then again, another cause, these are all separate, of anaphylaxis requiring more than 1 dose of IM epi, I would definitely be concerned for a biphasic reaction. Delayed epinephrine administration, so more than that 1 hour onset, is concerning, and then they should be monitored in the ER longer. If they have any of these triggers, they should at least be monitored for the 4 to 6 hours. Here on TREKK, this little chart is on TREKK if you need it. They have mild anaphylaxis, 1 dose, they remain asymptomatic. You can safely discharge them after 2 hours, as long as, again, they have epi prescription in hand, they live close to the hospital if needed. There's other factors like individualized, but again, I discharge in 2 hours all the time. If they have any of those risk factors we just talked about, I would monitor for at least 4 to 6 hours. And then, so like requiring 2 doses, here in the chart, it says it's late, they're far away, they have limited access. And then again, if they're in severe anaphylactic shock, severe respiratory distress, needing more doses, it's drug induced. If you're thinking like, I need to call the PICU, they're in impending respiratory or cardiac failure, you're just going to transfer here and going to admit the patient. So yeah, there is an asthma action plan if you are going to discharge a patient within the 2 to 6 hours. And then this is like CHIO's asthma action plan, which is also, there is a link on TREKK that you can like access this asthma action plan as well. It just says what to look out for parents, because again, underdiagnosed with parents, they are just like, oh, I was so close to the hospital. I really just bought them here. I didn't want to give them the EpiPen. I was scared. Just empowering them to do it early, that IM Epi is the treatment. And then talking about like common exposures and how to prevent it. And then again, there is the bottom line recommendations, which is basically everything we talked about in a nice little summary, also on TREKK if needed. And then in summary, if you're thinking anaphylaxis, so the rash plus other system, or severe respiratory or hypertension, you should just treat. Think it, treat it. You should look for reasons why it is, not why it isn't. Antihistamines do not treat anaphylaxis. Always remember to remove the offending agent. And even like that kid that got admitted to the PICU, if things aren't making sense, you're treating adequately, you don't know, you could dig and look to treat more. Always IM Epi, always in the anterior lateral thigh, unless for cardiac arrest or when you're starting the drip if needed. And then remember, like urticaria has other causes if needed. So again, if the IM Epi is not working and it's just skin manifestations, I would think it's not anaphylaxis.